Okay, so let us start. I want just to go for spot diagnosis. Spot diagnosis. So what is this?
This is buckling of the mouse, most likely scleroderma.
Thank you very much. This is a spot diagnosis, and this is the most common case in the exam. And this you will never miss in the exam because the patient usually putting a mask. So this to remind you in the exam, whenever you have a rheumatological case, you should ask the patient to remove the mask and inspect the face. Please never to forget to ask for removal of the mask and inspection of the face. This is a spot diagnosis. This tapered nose, puckered mouth, and there is telangiectasia of the skin. This is a spot diagnosis. This is a spot diagnosis. So please be careful in the exam because you should ask the patient to remove the mask and look for the face. Sometimes they call it the bird nose and the fish mouth. Don't use these words in the exam because this again is the patient welfare. Use the puckered mouth and the tapered nose and the telangiectasia. This is the telangiectasia very closely. So telangiectasia means dilatation of the capillaries under the skin. Capillaries are dilated and visible under the skin. This is scleroductile. Look for the skin of the hands. You will find glistening skin. So that's why you never to forget to pinch the skin and to make sure that there is no scleroderma. This is scleroductile. Ductile means the fingers. Scleroductile. And there are some what we call calcinosis. Calcinosis will cause pressure on the skin and infarcts on the surface of the skin. You will find infarcts on the surface of the skin. So this is calcinosis. The spots are calcinosis with some infarcts on the surface of the skin. There may be changing in the color of the skin. Changing in the color of the skin will indicate the presence of
Raynaud's.
Raynaud's. So think about whenever you see this case, think about calcinosis, think about Raynaud's disease or Raynaud's phenomena, think about esophageal dysmotility, think about scleroductile and telangiectasia. This is CREST. So CREST means all the manifestations of limited scleroderma. Limited systemic sclerosis or scleroderma. So this is the disease which is the most common case in the exam. It's about systemic sclerosis. Systemic sclerosis, you think about whenever you see this case, think globally. Take all the case in one shot in your brain. So what about this case? This case is very important in the exam. Think about manifestations to collect signs. Collect signs. Scleroductile, calcinosis, Raynaud's phenomena, puckered mouth, tapered nose, telangiectasia, and the most important is the effect internal organs. It will affect the esophagus, esophageal dysmotility. It will affect the cardiovascular system. It will lead to hypertension. It affects the kidney. It will cause nephropathy. And nephropathy sometimes will lead to hypertension. And hypertension may be in hypertensive crisis. You should ask the examiner about the blood pressure. You should ask about the blood pressure. What else? Pulmonary fibrosis, interstitial lung disease, pulmonary fibrosis. This is a killer in the exam. Why? Because you should put your stethoscope on the back of the patient and listen to the basis of the lung. You will hear the fine crepitations which are not changing with coughing, these are end inspiratory crackles or end inspiratory crepitations, which are not changing, they are fixed, not changing with coughing. Thank you very much. You got the case. Believe me, all the case is about the complications or associations with this systemic sclerosis. It's about esophageal dysmotility. It's about cardiovascular manifestations. It's about pulmonary complications or chest complication or respiratory complication in the form of pulmonary fibrosis and pulmonary hypertension. Pulmonary hypertension. So if you have limited time, examine the rheumatological aspect of the disease. If you have more time, you should examine for cardiovascular manifestations. At least you check for right ventricular hypertrophy. You should examine. You can examine for deviated or any. I hear some background, so please unmute. So in this case, take it as a comprehensive approach. Comprehensive approach, whenever I see this case, I should think about all the internal complications. Internal complications, the most important is cardiovascular, GIT, and pulmonary. Respiratory complications. Respiratory complications, there will be pulmonary fibrosis and interstitial lung disease, fine crepitations, which are not changing with coughing, and in respiratory crackles, and in respiratory crepitations, which are not changing, like moving the stethoscope on air. This is how you will diagnose the crepitations, fine crepitations of pulmonary fibrosis. What is the complications? This will lead to pulmonary hypertension. You may find enlargement of the right ventricle and right ventricular hypertrophy. This will lead to the apex of the heart will be displaced outwards, and there will be right ventricular heave or left parasternal heave of the right ventricular hypertrophy. There will be palpable B2 in the second intercostal, left intercostal space of the pulmonary area. Palpable B2. There will be raised JVP. That's why, because the problem is whenever we see these rheumatological cases, we don't know what to examine. We examine the hands, we go for the hands and examine the hands, and we don't take it as a systemic disease. So systemic disease, we should look for the face, we should look for the hands, and we should examine the joints, we should examine the hands, and we should be very careful whenever we are handling this patient, because we should examine the heart, at least for JVP, examine for JVP, examine for the apex beat, palpate for the apex beat, palpate for the right ventricular heave, palpate for B2 for palpable B2 in case of pulmonary hypertension. Examine the patient for edema, case of right side heart failure, and listen to the basis of the lungs. And please never, ever to forget to examine for carpal tunnel syndrome. Carpal tunnel syndrome, we have two tests, Fallon test and tunnel test. The two tests are killers. You should ask, and this test, you should ask the examiner, I will examine for Fallon test. Is it okay? Okay, I will examine for tunnel test. Tunnel test, tapping in the over the nerve, the median nerve. So if there is pain or electrical shock, this is painful to the patient. If you do it without permission from the examiner and asking the patient, this will lead to compromising the patient welfare, because the patient will feel electrical shock in the hand, electricity. So this is not good for the patient. So you should excuse the examiner and excuse the patient. And even you can ask the patient, if I tap here, tunnel test, if I tap here on the medial nerve, I will tap here. Do you feel pain or electrical shock? He will say yes. This is positive test. Even if you don't do the test, just ask the patient, if I will tap here, do you feel pain or discomfort in the hand? Yes, this positive tunnel test. If you put the back of your hands together in right angle with the forearm and the breast, do you feel pain or discomfort? Yes, this Fallon test. So this is the case. This is all about the case, and the examiner will ask you what is the complications. The complications, sometimes it's renal. It will lead to hypertensive crisis. It may lead to renal nephropathy. It may lead to esophageal dysmotility and recurrent GIT problems, which are not relieved with BBIs. So this is spot diagnosis. Manifestations are sclerodactyly, calcinosis, telangiectasia, Buccal mouth, tapered nose. If you tell the examiner like this, you got the full mark, because it's 10 minutes. You will take 6 minutes examining the patient, and 6 minutes more than enough to examine the hands, to examine for carpal tunnel syndrome, to listen to the basis of the heart, and to examine the heart if possible, or if you have time, you tell the examiner, I want to examine the cardiovascular system, I will examine the heart. Examine the heart for what? Examine the heart for displaced apex beat, right ventricular heave, and the palpable B2 in the second left intercostal space. This is the pulmonary area. This is indicator of pulmonary hypertension. What else? I examine the chest for basal, fine, basal, fine, and inspiratory crackles, which are not cleared or changing with cuff. This is the diagnosis of pulmonary fibrosis, and this will give the examiner impression that you are professional and you are getting the full examination and full diagnosis, and you will get the full mark immediately without even asking about the differential diagnosis, because this is the diagnosis, and the diagnosis is spot diagnosis. You got the diagnosis, you'll be asked about the complications and about the management of the case, what is the investigations, and the investigations usually you will ask about the autoimmune profile, What is this?
Mutulans, I'm sorry.
Okay, so this is rheumatoid arthritis with all the deformities of rheumatoid arthritis. So rheumatoid arthritis, you may have deforming arthropathy. Deforming arthropathy is any change in the shape of the joints. Any change in the shape of the joints. Any change in the joints. This is deforming arthropathy. Deforming arthropathy, we have what's called Jacob's arthropathy, and we have rheumatoid arthropathy. What is the difference? Jacob's arthropathy is related to any change in the tendons around the joints. So this will be deformity can be reversed. It's correctable. In case of the problem or inflammation of the joints themselves and destruction of the joint, this will be irreversible and cannot be corrected with some movements. We correct the joints by two ways. Ask the patient to do the prayer sign and ask the patient to make a fist. Never to try to change the position of the joint by your hand. This again is the patient welfare, and this is a failure in the station. Never to ask the patient to move if there is pain. So ask the patient and be very careful. And whenever you ask the patient to do any movement, you should ask the patient permission before any movement of the joints or any touch, even of the joints. Whenever you are examining the joints, in order to be professional, you should inspect, look, feel, and move. Look, feel, and move. Look for the type of deformity. Look for the type of deformity. Which joints and what is the type of deformity? We have boutonniere deformity. We have Z deformity of the thumb. We have the boutonniere and swan neck deformity. And we have ulnar deviation and metacarpophalangeal laxation of the metacarpophalangeal joints. So these are the deformities that you may find, and usually rheumatoid arthritis is sparing for the distal interphalangeal joints. If there is any problem to the distal interphalangeal joints, think about psoriatic arthropathy and think about osteoarthritis. This will involve the terminal or the distal interphalangeal joints. So rheumatoid arthritis is a spot diagnosis, but be careful if this deformity is related to the pathology, to the joints, inflammation of the joints, or to the tendons around the joints. If it is related to the tendons around the joints, this in case of systemic, any other rheumatological disease, systemic lupus erythematosus, systemic sclerosis, any other disease, this will be correctable, and you will ask the patient to do the prayer sign and to do the feast.
Your voice is breaking.
Sorry?
So your voice is breaking, sir.
My voice is breaking. Is it for you or for all of you?
Yeah, I'm hearing you clearly, doctor. I don't know. Maybe from you, doctor.
Okay.
Yes, sir.
Okay, doctor. So anyway, sometimes it's a connection, maybe from your side or from my side. So I hope now my voice is clear, because this is very important session. I want everyone to be clear and to be recorded and to have reference, because this case is easy in the exam. So look, by inspection, you will look for everything. Look for everything. Look for the skin, the color of the skin. If there's any glistening of the skin, sclerosis. So scleroductile sclerosis of the skin will be tight and glistening. Look for the color of the skin. If there's any redness or any pallor or any cyanosis or any change in the color, Raynaud's phenomenon, by inspection. Maybe pallor, maybe white color, maybe bluish color, maybe red color. So look for the color of the skin. Look for scars, any scar for correction or for relieving carpal tunnel syndrome. They will use, you will find the scar at the rest area, you will find the scar. Look for the deformity, look for the shape, look for the nails, look for if there's any psoriatic arthropathy, you will find psoriasis. Look for the skin. Never to forget to ask the patient to show you the elbows. Why the elbows? In order to check for the skin rash, characteristic of psoriasis, on the elbows, on the extensor surface of the joints. You will find the psoriatic lesions. So ask the patient to show the hand, ask the patient, look for the nails, look for the fingers, look for the carpal tunnel syndrome, look for the pulse, ask about blood pressure, look for the elbows. So in inspection, a lot of things, and put it in a checklist. Make like checklist. This is your role and this is your homework. Make checklist. checklist for things to look for by inspection. Look for the skin, look for the shape of the joints, any deformity, any swelling, any redness, and then feel. You will feel the temperature. Put the back of your hand on the joints and on the forearm to compare if there is hotness of or increased or raised temperature of the skin over the joints. This means active inflammation of the joints. Active inflammation of the joints. So inspect and feel. You feel the temperature. So very important to move the joints. And moving the joints, you will have 3 types of movement. 3 types of movement. You will ask the patient to move and look for any. This is active movement. Move the different groups of muscles around the joints and ask the patient to move the hands in all directions, and then ask the patient to move against the resistance. And against the resistance, this is passive movement, or sometimes against resistance is painful for the patient. So be very careful. Whenever you are moving the joints, be very careful. The third is skilled movement. Skilled movement, you will have a coin or a key in your pocket. And whenever you are examining the hands of the patient, use a pillow. Use a pillow. Don't examine the patient on air. Don't ask the patient to examine the patient while the hands are hanging in the air. So please ask for a pillow and put the patient hands on the pillow while you are examining, and make sure in this station you will find the pillow beside the patient. Put the pillow under the hands. So 2 B's. What is the first B? You should ask the patient if there is any pain. The second B is pillow. And the pillow, you should support the hands on the pillow before examining the joints of the hands. So these are very important notice. For skilled movement, you will ask the patient to pick a coin or a key from the pillow, or to button or unbutton the buttons of the shirt, or to write in a paper, if you have a paper and a pen, to ask the patient to write on the piece of paper. This is the skilled movement, and this is the most important in the exam, because this will decide about the ability of the patient to perform daily life or not. This patient will need support in case of working, so by occupational health officer or by social worker to help at home. So this is very important points. So these are the deformities, and it's a spot diagnosis. The Z deformity of the thumb, the Z deformity of the thumb, and we have 2 deformities of the fingers. We have the boutonniere and the swan neck deformity, and the ulnar deviation of the metacarpophalangeal joints. Ulnar deviation. This is the rheumatoid hand, and whenever you see this, ask the patient to do the prayer sign and ask the patient to make a fist. This will differentiate between Jacob arthropathy and actual inflammatory arthritis. So arthropathy means deformity, correctable. Jacob's arthropathy. This correctable deformity we may find in any rheumatological disease. Systemic lupus erythematosus may be found in case of, for example, systemic sclerosis, case of dermatomyositis. Any rheumatological disease can cause deforming arthropathy. So that's why you should differentiate by asking the patient to do the prayer sign, and ask the patient to make a feast. So this is how you differentiate between actual arthritis and arthropathy. There are some underlying causes for arthropathy. It may be inflammation of the joints. Inflammation of the joints, there will be fluctuation of the joint. Whenever you touch, you will examine the joints for fluctuation, and this is inflammatory arthropathy, and this is rheumatoid arthritis. In case of other arthropathy, for example, in case of osteoarthritis, it's a mechanical disease. Mechanical disease means that there is roughness of the joint and there is no inflammation. There will be just damage of the joints because of damage of the cartilage and the part of the bone adjacent to the cartilage. So in case of osteoarthritis, the problem will not be inflammation, but it will be mechanical. That's why how you can differentiate between mechanical and inflammatory by timing. If the problem is in the morning, it's related to accumulation of inflammatory mediators in the morning, so the pain and the stiffness will be more in the morning, and it will be relieved during the day. If it is mechanical, like osteoarthritis, the pain will be relieved by the end, will be increased by the end of the day because of using the joints while there is no lubrication, dryness, and the cartilage is damaged and the bone is damaged. This will cause pain while using. So this will increase by the end of the day, while in case of inflammatory arthropathy, the pain and stiffness will be more in the morning. This one important point to be put in mind whenever you are taking history about pain in the joint in any station, even in history take. Joint pain, you should ask, please show me your hands. Swelling, please show me the swelling. Skin rash, please show me the skin rash. You should look because it's mostly spot diagnosis. When the pain and the difficulty in movement, is it in the morning? In the morning, it's inflammatory. Rheumatoid arthritis. If it is by the end of the day, it's related to mechanical osteoarthritis. Skin rash equal psoriatic arthropathy. Psoriatic arthropathy, it's a spot diagnosis. You will find the skin rash in the hair edge. In the hair edge, you will find the skin rash, psoriatic skin rash in the hair edge, in the nails, subungual, psoriatic lesions, and you will find in the elbows and in the knees. This is psoriatic arthropathy. So if you have psoriatic arthropathy in the exam, think about the associations, because all autoimmune disease come in packages. So in all patients with any autoimmune disease, rheumatological diseases, think about other autoimmune disease. Autoimmune thyroiditis, hypo or hyperthyroidism, Graves' disease or Hashimoto's disease. Think about Addison disease, adrenal insufficiency because of autoimmune antibodies, Addison disease. Think about pernicious anemia. Think about type 1 diabetes. Think about inflammatory bowel disease. Think about celiac disease. All these come in one package. So that's how you approach the case. Put in mind all other autoimmune diseases that may be associated. Whenever you have a case of vitiligo, examine the thyroid. Because usually you will find some autoimmune thyroiditis. Autoimmune thyroiditis, either Hashimoto's, which will be associated with multinodular goiter and hypothyroidism, or Graves' disease with its package in ophthalmopathy, and in case of you will find proptosis, and you will find exophthalmos, and you will find manifestations of hyperthyroidism. Vitiligo is very easy spot diagnosis, and usually we get mental block. This is spot diagnosis, this vitiligo. What should I do for the patient? What I will examine? I examine what? Examine the thyroid. Examine the thyroid. And you should ask, if you are taking history, you should ask about the package of autoimmune disease, about celiac disease, malabsorption syndrome, bulky, pale, difficult to flush stool. This is the key word for any malabsorption syndrome. Inflammatory bowel disease, diarrhea, bloody diarrhea with loss of weight and anemia and the manifestations of anemia. Yes, doctor. Okay, so ask about thyroid, hypothyroidism or hyperthyroidism. Any change in your body weight, gaining weight or losing weight. Any intolerance with weather or any change in the weather preference, hypo or hyperthyroidism. Any change in the menstrual cycle for premenopausal ladies, this is diagnostic of thyroid disease. Even if you have in your clinic patient with hypo or hyperthyroidism and you give medication, in order to know if this patient or this lady premenopausal is having AU or hypo or hyper, with medication, you should ask about menstrual history. If the menstruation is regular or irregular, when last time you had your period, is it heavy or is it normal amount of bleeding? This is very important to differentiate between different status of thyroid. So it's all one package. Let us again enumerate. Any rheumatological disease, and by rheumatological disease, I mean rheumatoid arthritis, systemic lupus erythematosus, systemic sclerosis, dermatomyositis, ankylosing spondylitis, any other arthropathy which is related to autoimmune diseases. The second is type 1 diabetes. The third is thyroid autoimmune thyroiditis, either Hashimoto's or Graves' disease. Then Addison disease, then celiac disease, inflammatory bowel disease. We said type 1 diabetes, pernicious anemia, vitiligo, psoriasis, inflammatory bowel syndrome, and sometimes we can add some bullous diseases, pemphigus vulgaris and bullous pemphigoid. This all one package. Whenever you are examining a patient with any of these, think about the other package or associations with other autoimmune disease. This is the golden advice in general for the exam. So again, these are the rheumatoid nodules. Rheumatoid nodules. So rheumatoid nodules may be found on the knuckles or on the interphalangeal joints, or sometimes found on the elbow. Rheumatoid nodules. That's why it's very important. Show me your hands and look in the elbows by inspection for any skin rash. In case of psoriatic arthropathy, you will find the terminal of the distal interphalangeal joints are involved, and you will find the skin rash, characteristic skin rash. Otherwise, look for the nodules, rheumatoid nodules. Rheumatoid nodules. Rheumatoid nodules. This is spot diagnosis. spot diagnosis. Rheumatoid nodules. This is psoriasis. This is psoriasis. So whenever you are examining the patient, look for this here. Psoriatic arthropathy is very similar to rheumatoid arthritis. It's very similar. So in order to make sure that this is psoriatic, look for the skin, look for the nails. Psoriatic arthropathy with affected nails, or psoriatic arthropathy with psoriatic lesions on the elbows, and you will find the skin characteristic skin rash, hyperkeratotic rash with, if you scratch, you will find the bleeding from the lesions. Psoriatic arthropathy. Psoriasis. Psoriatic arthropathy will involve the terminal interphalangeal joints. The distal interphalangeal joints. Psoriatic arthropathy. You will find psoriatic nails. There is psoriatic lesions in the nail bed. This is very characteristic of psoriasis. And usually look for psoriasis in the edge of the hair. The hair edge, you will find the psoriatic hyperkeratotic lesions, characteristic of psoriatic arthropathy. What is this case?
Raynaud phenomenon.
Yes, Raynaud's phenomena, and you will find the characteristic facies of systemic sclerosis in the form of tapered nose and puckered mouth, and you will find the sclerodactyly, glistening, difficult to bench skin, psoriatic. So this is systemic sclerosis. And you'll find telangiectasia of the skin and the calcinosis, and the change in the color of the skin. Systemic sclerosis. And I am getting all these pictures in order to make sure that not all deforming arthropathy is rheumatoid arthritis. Please remember and put it in your mind and take it as a note. Not all deforming arthropathy is rheumatoid arthritis. So don't rush into the diagnosis of rheumatoid arthritis in case of deforming arthropathy. Deforming arthropathy may be the differential diagnosis, rheumatoid arthritis, may be systemic sclerosis, may be systemic lupus erythematosus, may be dermatomyositis, may be osteoarthritis, may be other diseases like chronic gout, or may be related to osteoarthritis or psoriatic arthropathy. So all these diseases are differential diagnosis for any deforming arthropathy. So deforming arthropathy is not equal to rheumatoid arthritis. What is this case? What is the diagnosis for this case?
Systemic sclerosis.
Systemic sclerosis. What is the findings in these very characteristic facies?
Baker mouth.
Puckered mouth and tapered nose. Please remember, I am just getting many times in order to remember, because in the exam, under stress, we need to be prepared with many times repetition. So puckered mouth, tapered nose, telangiectasia, sclerodactyly, calcinosis, Raynaud's phenomena, and internally, you should think about esophageal dysmotility. You should think about pulmonary fibrosis, pulmonary hypertension, right side or core pulmonale, and right side heart failure, you should think about cardiovascular complications. You should think about renal complications, the nephropathy, and hypertensive crisis. Those patients may end up with renal failure because of nephropathy. So those patients are one package. Scleroductile. This is deforming arthropathy, but can be correctable because the problem is not in the joints, but there is no damage of the joints, but there is arthropathy.
Sir, apologies.
Yes, please.
Sir, due to the accent problem, I am unable to stand the but you are telling the finding in the face and nose. Is
The face,
puckered face and
back of the mouse. Back of the mouse is furrows. You will find furrows. So it's wrinkles around the mouse. This is back of the mouse. Back of the mouse is wrinkles around the mouse. Wrinkles around the mouse. So this is called back of mouse. It's a small mouse. Even if you ask the patient to put 3 fingers in the mouse, it will not be able. The patient will not be able to put 3 fingers. And it's round and it's small. This is what is called back of the mouse. Tapered nose here is very clear, and tapered nose is related to scleroderma. Scleroderma, the skin will be tough, rigid. Sclerosis means tough and rigid skin. Yes. Back of the mouse and tapered nose. Yes, please.
Thank you, sir.
Here,
Sir, can we simply call it microstomia, sir?
Sorry?
Microstomia, sir?
I cannot hear.
Sir, can we simply call it microstomia?
Microstomia.
Sir.
Microstomia, you can say, but here you just better to say back of the mouse, because microstomia may mean small mouse, but it's not the characteristic features of furrows and the furrows and the characteristic shape, which is back of the mouse. So use the back of the mouse instead of microstomia. Back of the mouse and tapered nose. You will find sclerodactyly. Sometimes you will find infarcts on the skin over calcinosis, because there will be accumulation of calcium deposits under the skin, and this is very clear in the X-ray. If you find the X-ray is very clear about this characteristic calcinosis, deposition of calcium under the skin. Here, even you find tongue telangiectasia. Tongue telangiectasia in systemic sclerosis. There is another disease called hereditary telangiectasia. So hereditary telangiectasia, this is a hereditary disease with telangiectasia all over the body and even in the internal organ. And this patient will present with recurrent bleeding from all orifices and may be presented with sometimes stroke or internal hemorrhages. This is very characteristic for systemic sclerosis. It's a spot diagnosis, and the case is very easy to catch. This is, what is this?
Raynaud phenomenon.
Raynaud's phenomenon. So Raynaud's disease and Raynaud's phenomena, think about the systemic sclerosis and sclerodactyly. Sclerodactyly. This is sclerodactyly. Here you will find, in this picture, you will find both the cyanosis or the change in the color of the skin because of Raynaud's phenomena and the glistening skin of sclerodactyly. Sclerodactyly. I'm repeating many times because this very easy case in the exam. CREST syndrome. CREST is CREST, calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. This is the package for CREST. Systemic sclerosis. It's a spot diagnosis, very easy. Here, the hand again, you will find some skin infarcts of systemic sclerosis over the calcinosis. Sclerodactyly. What is this?
Dermatomyositis. Gottron papules.
Okay, this is Gottron papules. I want to look carefully in order not to misdiagnose as psoriasis. Very close to the diagnosis of psoriasis. This on the knuckles of the hand, on the knuckles or on the joints of the hands, on the dorsum or the extensor surface of the hand, on the dorsum of the hand. This is Gottron papules. Gottron papules. What else you expect to find? You will expect to find what is called the heliotrope rash. Here, the heliotrope rash. The heliotrope, helio means sun. So the eye, it will be looking like the sun inside the rash. The rash is surrounding the eye. Heliotrope rash. Heliotrope rash. Here you will find dermatomyositis and polymyositis are sometimes associated. Dermatomyositis or polymyositis. So there is affection of the skin and affection of the muscle. And whenever we have myositis, you should think of CK. CK as a diagnosis for these diseases with the autoimmune panel, the autoimmune profile. Anti-nuclear antibodies, extractable nuclear antibodies, this will include all the package. Autoimmune package, inflammatory markers, and CK, inflammatory markers, erythrocytic sedimentation rate, and C-reactive protein. This is dermatomyositis. Dermatomyositis, you can ask the patient to get up from the sitting position to the standing position without using hand. And you examine for the ability of the patient to comb the hair. This is myositis, proximal myopathy, dermatomyositis, heliotrope rash, and Gottron papules. Heliotrope rash and Gottron nodules. Don't misdiagnose as psoriasis. These very characteristic features of dermatomyositis. This is the Gottron nodules, extensive Gottron nodules on Gottron papules on the dorsum of the hand. So this is dermatomyositis. It's a spot diagnosis. I am showing these pictures because this is the cases for the exam. What are the cases for the exam? Psoriasis with psoriatic arthritis, rheumatoid arthritis, systemic lupus erythematosus, dermatomyositis, ankylosing spondylitis. These are the cases, rheumatological cases for the exam. Dermatomyositis. I hope this is clear because heliotrope rash over the eyelids, Gottron papules, violaceous, erythematous, rash over the metacarpophalangeal joints and proximal interphalangeal joints. Sometimes you will find the V neck rash, violaceous, erythematous, anterior chest with telangiectasia, and sometimes very angular erythema and calcinosis. These are the 5 skin features of the dermatomyositis. Very angular erythema around the nails. The neck rash here, it's the neck rash. You will find the V shape because it's skin rash on sun exposure. So on sun exposure, and that's put it in mind and keep it as a golden note. Whenever you are asking in history taking about skin rash, ask about skin rash, and it's a twin skin rash on sun exposure. Skin rash on sun exposure, it's autoimmune disease, systemic lupus erythematosus or dermatomyositis or other autoimmune disease. This skin rash on sun exposure, you will find in the face, you will find in the V-shaped neck appearance and in the dorsum of the hands. It's related to the sun. Gottron papules, dermatomyositis. On the dorsum of the interphalangeal joints and the interphalangeal joints and the metacarpophalangeal joints. This is the heliotrope rash. You will find very characteristic color here, which is a violaceous color. It's like violet, so it's little bit purple in color. Violaceous rash, and this differentiated from the silvery rash or hyperkeratosis of psoriasis. This is a violaceous erythematous rash. In case of psoriasis, it's hyperkeratotic silvery scales. Silvery scales. This is a differential between the dermatomyositis, Gottron papules, and the very characteristic lesions, which will involve the subangular area and the hair margin, the edge of the hair or the hair margin. There will be hyperkeratotic silvery scales. If you scratch these scales, there will be bleeding under the skin rash. This is the characteristic lesions in case of psoriasis and in case of dermatomyositis. This is very characteristic skin rash of dermatomyositis. Heliotrope rash. Heliotrope rash. And Gottron papules. Violaceous color. I think now you will never forget these pictures if it comes in the exam. This systemic lupus erythematosus with its characteristic malar or butterfly rash. And I hope you can now differentiate between the heliotrope rash, malar rash or discoid rash of systemic lupus erythematosus, and lupus pernio. Lupus pernio will involve the nasolabial fold. If you find below the nose there is lesions and there is skin rash, this is lupus pernio. It's found in sarcoidosis, lupus pernio. Lupus pernio. This here, it's systemic lupus erythematosus. Here is the discoid lupus erythematosus or malar rash or butterfly rash. It's a sun exposure, skin rash on sun exposure. This is systemic lupus erythematosus, discoid rash. This is butterfly rash. It involves all, and there is no involvement of the nasolabial fold. It preserves the nasolabial fold. Very clear. So this is the butterfly rash. Very clear. So whenever there is a case of systemic sclerosis, think about the heart. Systemic lupus erythematosus. Think about the heart. Think about the brain. Think about the lungs. Think about the skin. Think about the kidneys. And the most important is the antiphospholipid syndrome, hypercoagulability. Antiphospholipid syndrome with possibility of deep venous thrombosis and stroke. And you can ask the female patient about recurrent miscarriages. Recurrent miscarriages. So it's very important to think comprehensive. That's why very important to ask about all the questions related to rheumatological disease if you are taking history, starting from the hair, starting from the eyes, gritty and red eyes, dry eyes, iridocyclitis, sometimes episcleritis, sometimes scleritis. The eye may be affected. The mouth, oral sores, oral sores. There may be dysphagia, difficulty in swallowing related to esophageal dysmotility in case of systemic sclerosis. So any disease related to the autoimmune disease, ask all the questions related to rheumatological disease. Ask about the joints, ask about the pain, swelling, deformity, and sclerosis, tightness of the skin, and ask about the skin and ask about the joints, pain, difficulty in movement, and stiffness of the joints. Ask about the kidney, frothy urine. Ask about any blood with waterworks. Ask about stones. Ask about any edema or swelling, kidney function. Ask about the blood pressure. Skin rash on sun exposure. About the lung, any pain in the chest, difficulty breathing, shortness of breath, coughing of blood. So you should take it as a comprehensive and ask about systemic manifestations or systemic complications. This is the malar rash preserving the nasolabial fold. If you find the skin rash is involving the nasolabial fold, this is lupus berennium. Diagnostic for sarcoidosis. This is the malar rash or butterfly rash, characteristic of systemic lupus erythematosus. Very beautiful. And spot diagnosis. Even if you find arthropathy, this arthropathy is Jacob's arthropathy. Jacob's arthropathy will be correctable with the prayer sign or with making a fist. Systemic lupus erythematosus, spot diagnosis. So what are the manifestations? Butterfly rash, pleural effusion, heart problem, lupus nephritis, arthritis, Raynaud's phenomena. All this may be found in case of systemic lupus erythematosus. This very beautiful demonstration of the butterfly rash. Butterfly rash. Spot diagnosis. Mixed connective tissue disease is a rare autoimmune disease diagnosed when a specific antibodies. So specific antibodies, these are the anti-U1 ribonucleoprotein antibodies. If these antibodies are present, this is diagnostic of mixed connective tissue disease, and there are features of at least two connective tissue diseases. Connective tissue diseases, by connective tissue diseases, we mean systemic lupus erythematosus, systemic sclerosis, and dermatomyositis. Polymyositis and dermatomyositis. Systemic lupus erythematosus, systemic sclerosis, polymyositis, and dermatomyositis. Ankylosing spondylitis, you will find a lot of findings. This is the patient with ankylosing spondylitis. The patient with ankylosing spondylitis. Ankylosing means fusion between the vertebrae. Fusion. Here it's very clear that there is fusion between the vertebrae. This is ankylosing spondylitis. Ankylosing spondylitis, spot diagnosis. What is called bamboo spine. Ankylosing spondylitis. What are the effects or the clinical picture of ankylosing spondylitis? You will find eye manifestations, pressure, sensitive to light, blurred vision, neck pain, sometimes heart problems, inflammation of the bowel, sometimes bowel incontinence, spine pain, loss of flexibility, spinal curvature, sacroiliac joint pain. And this may be the first presentation, sacroiliac joint pain. And you ask for X-ray or MRI to the spine, you will find sacroiliitis. Sacroiliitis. Lungs, lung problems, rib pain, chest tightness, trouble breathing because of deformity of the chest, scoliosis and kyphosis. Anterior uveitis, hyperkyphosis, spine curvature, hyperkyphosis, inflammation and back pain, malaise, heel pain, and pain in other joints. These are the rheumatological diseases, and these are the most common cases for the exam. So,
Sir, can you please tell us examination for ankylosing spondylitis?
for which case, the doctor?
Sir, examination if the patient comes in station 5, how will you examine a case of backache presenting as ankylosing spondylitis?
Okay, so usually you will find either the cases for the exam, you will find one of three. The patient is presented with joint pain, or patient presented with skin rash, or patient presented with back pain. So these are the three possible presentations for the exam. Back pain, it's ankylosing spondylitis. It's ankylosing spondylitis. Skin rash, think about dermatomyositis, think about systemic lupus erythematosus, think about systemic sclerosis, think about psoriasis, think about vitiligo associated with other disease. Other than that, it's joint pain. Whenever there is joint pain in the hands, think about all deforming arthropathy of the hands. And whenever you have a case in the exam, for example, in station 5, show me your hand. Show me your joint pain. Where is exactly? For example, if the joint pain in the knee, this is related to other causes. So show me your pain, the joint, painful joint. Show me the painful joint. Case of a skin rash, please show me the skin rash. Sometimes it's a spot diagnosis. If it's in the face, think about systemic lupus erythematosus. The characteristic features for systemic sclerosis, dermatomyositis, lupus, burning. In case of back pain, so it's a spot diagnosis, it's ankylosing spondylitis. So skin rash, think about psoriasis. Psoriasis, sometimes it's very easy case and it's a spot diagnosis, and you should examine the joints for look, feel, and move. Look, feel, and move. Let us take some examples of some cases. So rheumatoid arthritis, the scenario: joint pain, joint swelling, joint deformity, aches, shortness of breath due to sometimes it's related to pulmonary fibrosis or interstitial lung disease. So if you are taking history, ask about the joint pain. Which joints are affected? When the pain is worse, if it is in the morning, this is related to inflammatory. If by the end of the day, it's related to mechanical arthrosis. Do they ever become hot and swollen? Do they feel stiff in the morning? And for how long? For how long? Thus, this is giving a hint. If it is more than 1 hour, it's more inflammatory and more rheumatoid arthritis. Do you take painkillers? Which one? Do they help? Do you use anything like ibuprofen? And does it cause any complications or side effects like heartburn? Have you noticed any eye redness, painful or dry or gritty? So start from the hair falling, alopecia. Case of systemic lupus erythematosus, some rheumatological disease, you will find alopecia, falling of hair. Ask about the eye. Ask about the skin rash, lumps and bumps. If any swelling, even in the neck for thyroid, shortness of breath, cough, complications related to the chest, complications related to the GIT, mouth sores, any difficulty in swallowing, systemic sclerosis, any recent infections, medications, show me your medication list. So all these questions are very important in case of any rheumatological disease, joint pain, joint swelling, stiffness, difficulty in movement, deformity, skin rash, any of this, ask about the rheumatological package. This is a cluster for rheumatological diseases, and never to forget to ask about chest, GIT, cardiovascular, and renal. Not only skin and joints. Systems to examine. For the routine, start at the hands. Checking, so general examination, look, inspection, any skin rash, psoriatic nail changes, look for the main differential, the joints, the dorsum of the hands, feel the joints and radial area, look for synovitis, fluctuation, and please make sure before you touch the patient, ask about pain. You have any pain in the joints, any tenderness? If you feel any pain while I'm touching you, please tell me and I'll be more gentle. This to compromise. because no way to lose the patient welfare mark. Patient welfare is a killer. If you do anything and the patient say, this is failure. So please be careful, because those patients are on pain already. So never to touch the patient without taking a permission and telling the patient, if you have any pain, I'll be gentle. And be very careful. Put a pillow and examine very carefully, and make sure whenever you are touching the patient, look at the patient's face to make sure that there's no pain. Check for nodules on the extensor surface of the arms for psoriasis, hand back, and go for any wasting of the muscles, scars, erythema, sensation. Check for sensation, and check for sensation with a piece of cotton, not with the pin prick or the new pin. Check for sensation with piece of cotton, fine touch. If you will examine the sensation in the hands, look for the movement, examine the movement, passive, active, and by skilled movement. Feel for the temperature, feel for tightness of the skin, pinch the skin, and feel for the tightness in the scleroderma or scleroductile. So check for the movements like the grip, finger pincer, to make like pincer in the index and thumb, and try to just get in between the two fingers if it is this what's called the pincer test, and the rest movement before asking them to do specific tasks like writing or doing a button or unbuttoning. So this is the skilled movement, and to grip or to take the coin or key from the on the bill. Once you have satisfied yourself as symmetrical deforming polyarthropathy, this is characteristic of rheumatoid arthritis. This is symmetrical deforming polyarthropathy. So what are the deformities? The ulnar deviation of the metacarpophalangeal joints, the boutonniere deformity, and the Z thumb, and the swan neck appearance, the swan neck deformity. So what important and never to forget to examine is the lungs. So the lung basis for, listen at the lung basis for fibrotic changes. Fibrotic changes means lung fibrosis or pulmonary fibrosis or interstitial lung disease, and then lie the patient flat and look for spleno and hepatomegaly. Why splenomegaly? What is the syndrome which involves splenomegaly? Feltis syndrome.
Feltis syndrome.
Very, very good. Thank you very much, Doc. Feltis syndrome. Feltis syndrome, you will find the splenomegaly and rheumatoid arthritis, and the splenomegaly and leukoplakia. So look for cutaneous vasculitis rash, nail fold vasculitis, palmar erythema, rheumatoid nodules at the elbow, erythema nodosum, polyderma gangrenosum, bioderma gangrenosum, which is one of the characteristic features of ulcerative bioderma gangrenosum, is associated with
inflammatory bowel disease.
Inflammatory bowel disease. Thank you very much. Inflammatory bowel disease, and specifically ulcerative colitis. So you will find the look for the skin for any characteristic rash. Erythema nodosum may be found with tuberculosis, may be found with sarcoidosis, musculoskeletal system, symmetrical arthropathy of the small joints of the hands with ulnar deviation. This is how you present your case to the exam. And please never to forget to examine for carpal tunnel syndrome. Carpal tunnel syndrome. So how to present your case? Symmetrical arthropathy of small joints of the hands with ulnar deviation, dorsal subluxation, Z-thumb, boutonniere, and swan neck deformities. There is wasting, features of carpal tunnel syndrome, thenar wasting, weakness of the thumb abduction and opposition, sensory loss over the lateral 3.5 digits on palmar aspect. There is positive tunnel test and Fallon test, carpal tunnel release scar. Comment on the presence or absence of active synovitis by doing the fluctuation test and the functional loss caused by the disease, pattern writing grip strength. Ocular erythematous, dry eyes, respiratory fine end and respiratory crackles or crepitations on the lungs, which are not changing with coughing. Stony dull percussion note. Stony dull percussion note means that sometimes there is tense pleural effusion, or sometimes it's related to dense fibrosis, pulmonary fibrosis. So this is how to present your case, how to collect the signs, and how to present the case to the examiner. This is very important notes about any rheumatological case. If there is, for example, splenomegaly, Felty syndrome, and you will not have time to do abdominal examination for hepatosplenomegaly, so, or do cardiological examination for any cor pulmonale or for pulmonary fibrosis. So just put your stethoscope on the back of the chest. Neurological, atlanto-axial subluxation can lead to cervical cord compression and spastic quadri or paraparesis. This is not the case in the exam. You will not find this up to this level of complications. Differential to exclude osteoarthritis, you will find nodal osteoarthritis, inflammation, so HLA-B27 associated psoriatic inflammatory bowel disease, sexually acquired infection or infective diarrhea related to, for example, reactive arthritis. Systemic lupus erythematosus, usually Jacob's reducible deformities. In case of systemic lupus erythematosus, sarcoidosis, you will find lupus pernio, and you will find the erythema nodosum on the lower limbs. Crystal gout and pseudogout, infective septic arthritis, Staphylococcus aureus, gonococcal tuberculosis. This is infective or reactive arthritis. Parvovirus-related hepatitis, Lyme's disease, rarities, some rare conditions, multiple or multicentric reticulohistiocytosis. So this is not a common case for the exam. Investigations, urine diagnostic for proteinuria, kidney. Think first about the kidney. Nephropathy. Secondary to membranous nephrotic syndrome or amyloidosis. Check the temperature for infection, oxygen saturation, lung fibrosis, calculate the, I'm not sure what is this, but anyway, baseline disease activity score. This is a score system for the activity of the disease. If the disease, what's called DAS 28, this scoring system for activity of the disease. Baseline disease activity score, useful in monitoring activity from visit to visit and response to treatment. Blood test, think about all the blood tests possible, but the most important is to think about rheumatoid factor and CCB. CCB is the diagnostic for the disease, CCB. Rheumatoid factor and CCB. Any other tests, you should think about anti-nuclear antibody and extractable nuclear antibodies, imaging, plain radiology for the joints, and MRI for the joints. Sometimes we do ultrasound for the joints. Joint aspiration, so this in case of you want to make sure there is to confirm the diagnosis. Management, non-pharmacological, education, information, support group, physiotherapy, occupational therapy, social worker, podiatric, specific advice for hot and swollen joints, and elevate. So medical treatment, it's mainly about the staging of the disease. So mild disease, you can start with non-steroidal anti-inflammatory medications. So non-steroidal anti-inflammatory medication, this is the first line of treatment. And consider gastroprotection to give BBIs with the non-steroidal anti-inflammatory and to make sure there is no contraindication for this medication. If there is renal impairment or history of peptic ulcer disease, you should be careful. Intra-articular steroids, intramuscular steroids in case of flare, and waiting for disease-modifying anti-rheumatic drugs. Disease-modifying anti-rheumatic drugs. Oral steroids, think about gastroprotection, bone protection, side effects of steroid, and use of medical alert bracelets. Disease-modifying anti-rheumatic medication start early with methotrexate. So usually in those patients, we use a steroid with caution, and it's preferable to start with DMARDs. DMARDs, these are disease-modifying anti-rheumatic drugs. What are these medications? These are methotrexate, sulfasalazine, leflunomide, and leflunomide, it's called Arava. Leflunomide is called Arava. Arava is the trade name for leflunomide. Hydroxychloroquine. Hydroxy is this anti-malaria drug. So I hope this is very clear, because these medications, you will be asked about how to treat this patient, non-steroidal anti-inflammatory, and DMARDs. And think about steroid, but role of steroid is very limited, and you should start very early the DMARDs. What are the DMARDs? Methotrexate, leflunomide, and sulfasalazine, and hydroxychloroquine. And the rheumatologist usually start with methotrexate and plus hydroxychloroquine. These are the most important. What other medication? Monoclonal antibody therapies like anti-tumor necrosis factor, anti-interleukin 6, abatacept. These are the monoclonal antibodies, biological treatment. If the DMARDs fail, you will start. So there are three main lines for all autoimmune diseases. Non-steroidal anti-inflammatory with gastrointestinal protection. The second is DMARDs. Oral steroid has limited role. You should start DMARDs early with methotrexate, sulfasalazine, leflunomide, or hydroxychloroquine. If failed, start with biological treatment or anti-tumor necrosis factor or anti-interleukin 6. Abatacept, surgical joint replacement, joint fusion, tendon transfer, whatever. What do you need to tell the patient before they start the methotrexate? Explain that it is not painkiller. It works as reducing inflammation over a long period of time and prevents flares from happening and long-term joint damage progression. As a result, start the same time as short course of steroids, and then you will withdraw or tapering the steroids with replacement with DMARDs. Because of depression or suppression of the immune system, they are more at the risk of infection, and simple infection may become more severe than normal, so we should advise them to seek medical advice early, and you should do white blood cell count. White blood cell count. So white blood cell count is very important in case of methotrexate or immunosuppressive medication, and if it is lower than 2, it should be stopped. And there should be the methotrexate is taken once a week, followed by a 6-day break, and they will need to baseline blood test and chest X-ray because methotrexate may lead to pulmonary fibrosis and hepatotoxicity. So you should do regular blood tests, you should do X-ray, you should do liver function test and white blood cell count, and the patient should, again, is drinking a lot of alcohol because it's not advised to drink alcohol while taking the medication. So there should be avoiding some vaccination, and the patient shouldn't be pregnant on it. So the patient should seek advice about the pregnancy while taking the medication. What diagnostic criteria are used in rheumatoid arthritis? The American College of Rheumatology criteria can be applied in those with synovitis and a clinical suspicious of rheumatoid arthritis. The criteria include 4 key areas: number and size of joints affected, the duration of the symptom, and the serology about CCB and ESR and C-reactive protein. These are the criteria for follow-up of rheumatoid arthritis according to the American College of Rheumatology. So this file should be read many times in order to get all the information, and this is the rheumatoid arthritis case. Very common in the exam, and the questions are the same. What are the investigation and how to manage this case? Whenever you hear the management, think about non-pharmacological, pharmacological, and surgical treatment. Scleroderma. I love this case because, as I said, it's a spot diagnosis. Ask the patient to remove the mask, look for the back of the mouth, tapered nose, telangiectasia, sclerodactyly, calcinosis, Raynaud's phenomena, esophageal dysmotility, cardiac complications, hypertension, renal crisis. Think about GIT, esophageal dysmotility, and think about the high blood pressure, hypertensive crisis. Think about the vascular problems, the Raynaud's phenomena, and sometimes the change in the color of the hands, calcinosis, infarcts in the fingers, infarcts, and sometimes even gangrene of the tips of the finger. Cold hands, joint pain, hand swelling, skin tightness, problem with the swallowing, shortness of breath. These are the differential diagnosis of presenting symptoms. For all rheumatological cases, imagine the patient in front of you and start with the hair, the eyes, the mouth, the GIT, the chest, the skin, the joints, the kidney, the heart, and the urinary system, and the joints and the skin. Skin is very important. Skin rash and skin rash on sun exposure, tightness of the skin, Any other manifestations of the skin, lumps and bumps, any general manifestations like fatigue, weakness, lack of energy. So, as I said, the questions will be related to the systems which may be involved. Start with the skin, the joints, and GIT, chest. And this is about history taking in case of you are taking history or long case for MRCPI. Sometimes it comes as long case and sometimes it comes as short case, rheumatological case, and sometimes it comes as brief clinical consultation, station 5 for MRCP. Swollen extremities, non-beating, sclerodactyly, localized thickening of fingers and toes distal to the metacarpopharyngeal joints and the metatarsobpharyngeal joints. Telangiectasia, calcinosis, hypo or hyperpigmentation, determines the skin involvement. Sometimes it's localized systemic sclerosis. Microstomia, here, as our colleague mentioned, the microstomia may be used, small mouse, but Buccal mouse is better describing the presenting symptom or sign, which is furrows around the mouth, wrinkles around the mouth. Spiratory, fine end in respiratory crackles at the basis, do not change with cough. Cardiovascular, raised JVB, left parasternal heave, palpable B2, loud B2, peripheral edema. All this will give us the manifestations of pulmonary fibrosis and pulmonary hypertension and pulmonary core pulmonale. The reflection of the problem in the lung and pulmonary hypertension on the right side of the heart, the form of tricuspid regurgitation and sometimes even right side heart failure, right ventricular failure, which will be accompanied by edema and by fluid overload. So this part is very important for cardiovascular, for chest, and for rheumatological cases. In case of dermatomyositis, you will find mechanics hand, very angled erythema, Gottron babules, photosensitivity, heliotrope rash, and proximal myopathy. So this is in case of dermatomyositis and how to differentiate between systemic sclerosis or scleroderma and with dermatomyositis. In case of systemic lupus erythematosus, you will find the characteristic malar rash, Jacob's arthropathy. Jacob's arthropathy is correctable, deforming arthropathy. Correctable, deforming arthropathy. We have two types of deforming arthropathy, correctable or non-correctable. You will find scarring alopecia. That's why I'm telling you start with the hair. Imagine the patient in front of you and start with the hair. Look for the hair, look for the eyes, look for the mouth, mouth sores, mouth ulcers, look for the GIT, look for the skin, look for the joints, cardiovascular, respiratory, renal. So all the systems can be involved. Mixed connective tissue disease, you will find features of systemic lupus erythematosus, scleroderma, and polymyositis. Chronic graft versus host disease, this can be included as a differential diagnosis. Investigations, here investigations are very important. Bedside test oxygen saturation in order to check for interstitial lung disease. You will find poor peripheral perfusion, arterial blood gases, interstitial lung disease, check for the ABG, check for blood pressure, ask for blood pressure from the examiner, never to forget, because those patients may be presented with hypertensive crisis or sometimes with renal crisis. Scleroderma, renal crisis. Neurodiabetic for proteinuria in case of renal crisis. Also, glomerulonephritis rare in renal crisis. You should ask about blood pressure is the most important measure in scleroderma, contrast to other autoimmune connective tissue disease. ECG should be done, right heart strain. You will find ST depression and or T wave inversion in V1 to V3 and in lead 3. So these are manifestations of pulmonary hypertension and core pulmonary. So these are the most important complications: GIT complication, chest complications in the form of pulmonary fibrosis, interstitial lung disease, pulmonary hypertension, and core pulmonary. Please memorize this sequence, because this is the most important complications for scleroderma. Blood, you should examine for anemia. You should examine for kidney function test, blood urea and electrolytes, renal crisis, creatinine. If present, suspect also request blood film for fragments of red blood cells, and the specific antibodies, you should ask for SCL70. SCL is this from sclero, so SCL70. What other? You should check for anti-nuclear antibodies, and you should check for the extractable nuclear antibodies. This is the package for scleroderma or systemic sclerosis. Anti-centromere, this in case of limited systemic sclerosis or CREST syndrome. CREST syndrome, this you check by anti-centromere. So please remember 4 important antibodies. The first is anti-nuclear antibodies in order to check for association with other autoimmune disease. This makes it connective tissue disease. Check for SCL70, specific for systemic sclerosis, and anti-centromere. This is specific for limited systemic sclerosis or CREST. What is CREST? C for calcinosis, R for Raynaud's phenomena, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. Anti-RNA, so you will find a lot of other antibodies, but the most important is SCL70 and anti-centromere. Imaging, chest radiology for the pulmonary fibrosis, high resolution CT for, you will find ground glass changes and the honeycombing tracting, and sometimes you will find manifestations of bronchiectasis. Why bronchiectasis? This can be associated with any autoimmune disease, damage of the terminal bronchioles, dilatation of the terminal bronchioles, and accumulation of secretions and infection, chronic infection. Other tests for Raynaud's phenomena, it's capillary scopy. Capillary scopy. Capillary scoping, looking for abnormal nerve fold capillaries, and thermography with cold challenge for Raynaud's severity. These tests are not done because it's against the patient welfare. Spirometry, any chest investigations can be done. Spirometry, pulmonary function test, you will find restrictive lung disease. Restrictive means that there is pulmonary fibrosis or interstitial lung disease. Reduced transfer factor, this is lung diffusion CO test, you will find reduced transfer factor. Endoscopy for esophagitis. Treatment, take the important points in treatment. Non-pharmacological, education, counseling, physiotherapy, psychological therapy, psychological support, occupational health officer, social worker, hand warmers, avoiding the cold. These all included in the education and counseling of the patient. Occupational therapy, speech and language therapy, smoking cessation, and vaccination. Medical, prokinetics, antacids, cyclical antibiotics, calcium channel blockers. Calcium channel blockers is very important. Calcium channel blockers for high blood pressure, for renal protection, and for Raynaud's phenomenon. Calcium channel blockers, nifedipine. Phosphodiesterase 5 inhibitors, sildenafil, Viagra. Sildenafil, Viagra. This is phosphodiesterase 5 inhibitors. This will reduce the pulmonary hypertension. And it's indicated in all cases of pulmonary hypertension. So memorize calcium channel blockers, memorize PPIs, memorize nifedipine as calcium channel blockers, and sildenafil or Viagra. Prostacyclin infusion, iloprost. This is for pulmonary hypertension. Prostacyclin infusion, iloprost. Endothelium receptor antagonist, bosentan. Bosentan, this is the trade name for the endothelium receptor antagonists. These are vasodilators. All these are treatment for pulmonary hypertension. Anticoagulants, diuretics, and long-term or ambulatory oxygen therapy in case of pulmonary fibrosis or interstitial lung disease. I know a lot of names, so just remember as much as you can and read it many times in order to get the as much as you can from the names. Because I know some medications, they are difficult and not used in daily life, but the most important is PPIs for esophageal dysmotility and the problem to the acidity, and to protect even with other medication if you are using painkillers or anti-rheumatic medications. The second is calcium channel blockers. The third is sildenafil. These are the most important medication, and you should protect against if there is antiphospholipid syndrome or hypercoagulability or risk of embolism, use the anticoagulation and other medication for high blood pressure like diuretics. If the patient has pulmonary hypertension and pulmonary fibrosis, which is the most common complication of all autoimmune collagen diseases. Methotrexate, mycophenolate mofetil, cyclophosphamide. These are medication that can be used with all autoimmune diseases as immunosuppressive or immunosuppressive medication, specifically in case of lung fibrosis and in case of skin tightness. You can use even AC inhibitors. AC inhibitors will reduce the blood pressure and will be renal protection. surgical lung transplant, and contracture release if there is Jacob's arthrosis, excision of calcinosis because it will lead to infarction of the skin. What are the long-term risks of those with pulmonary fibrosis? Progressive respiratory failure, pulmonary hypertension, lung cancer, 5-time increased risk, and core pulmonary. What is the typical histological subtypes of pulmonary fibrosis? Non-specific interstitial pneumonia. What are the long-term risks of those with pulmonary hypertension? Core pulmonary, pulmonary thrombosis, and right side heart failure. Would use steroids in systemic sclerosis? No. Very little chance of benefit, and also an increased risk of infection and renal crisis. So corticosteroids are not considered in the treatment of systemic sclerosis. What is the mainstay treatment? The mainstay treatment is the immunosuppressive medication like methotrexate, mycophenolate mofetil, cyclophosphamide. These are the medication should be used. Methotrexate, the problem is it increases the pulmonary fibrosis. That's why it's better to be avoided. What is the mainstay? Mycophenolate mofetil and cyclophosphamide. This is the mainstay treatment, and treatment of complications: high blood pressure, renal impairment, pulmonary fibrosis, pulmonary hypertension, core pulmonary, and right side heart failure. How to investigate GIT disease in patients with scleroderma depend on the most likely site: esophageal, endoscopy, barium swallow, manometry, case of stomach, endoscopy, gastric emptying study, small bowel, hydrogen breast test, MRI or CT enterography, fecal elastase, colonoscopy, CT, anorectal proctoscopy, and the flexible sigmoidoscopy, anorectal physiology. All these are investigations related to the GIT. So the most important is to do upper and lower endoscopy. This is the summary of investigation for the GIT. So here, this one of the important cases. If you go with these two cases, you will cover all rheumatological diseases. Rheumatological diseases are rheumatoid arthritis, systemic lupus erythematosus, dermatomyositis, psoriatic arthropathy, and ankylosing spondylitis. So I hope this case is clear. So I will open the floor now for any questions. If you have any questions, please ask. Backup? Yes, backup. Okay.
Sir, can you please show us the rash of lupus pernio? What was different
Yes,
from the butterfly?
sure. Yes, I will show you the rash of lupus pernio.
Doctor, is sarcoidosis is common? It can come, we can make it example.
Which case? You ask about
Sarcoidosis.
sarcoidosis, because if a case of sarcoidosis will be presented with skin rash and pulmonary fibrosis. So it's a case of a chest, not a case for rheumatology. It's a case mainly for chest. So you find the very characteristic skin rash, which is lupus pernio, and you will find the very characteristic rash of erythema nodosa. So if you find these two rashes and you find pulmonary fibrosis, this is sarcoidosis. So here, look for the rash, you will find what? Involvement of the nasolabial fold. This is lupus burning. Very similar sometimes to lupus erythematosus, the malar rash or the butterfly rash, but here the characteristic feature, it's involving the nasolabial fold. I hope this is clear. This is the erythema nodosa. Characteristic for sarcoidosis.
And sir, can you please repeat the steps for examination of ankylosing spondylitis?
For examination of what?
Ankylosing spondylitis.
Ankylosing spondylitis. Okay. So I hope this is clear up till now.
Yes, sir.
Okay, so active and passive movement. Passive movement, the patient will do movement, check the patient, open your hands, close your hands, move the wrist. This is passive movement. So asking the patient to do active and passive movement. Passive movement, you move the joint yourself. You don't, the patient will not do any, you are just moving the joints yourself. This is passive movement. Passive means that there is no movement done by the patient. You are moving the joints yourself. Active movement, the patient will move the joints himself. Active movement. And sometimes you do the movement against resistance. Movement against the resistance, you ask the patient to extend and to flex and to move in all directions against resistance. So against resistance is active movement. Passive movement, you move the joints with your hand. So the patient will do no effort. Skilled movement, the patient will baton and pick up a coin or key from the bin. This is the skilled movement. An inspection, inspect for everything. For the skin, for the color, for the nails, for scarf, for deformity. Inspect for everything. So look, feel, and move. Feel, you will feel the temperature, the tightness of the skin, and the fluctuation of the joints. If there is any fluctuating joints, means inflammatory process. What is this?
Bakar in the mouse, multiple telangiectasia, and in the nose. It is
This
most
is very important for diagnosis. And never to miss this diagnosis in case of covered by the mask. So ask the patient to remove the mask. Whenever you go into a rheumatological case, ask the patient to remove the mask and inspect the face. Please, never to forget to look for the face. Ankylosing spondylitis. It's a spot diagnosis. You know the hyperkyphosis, and the patient is not able to move the neck. Ankylosing means fusion between the vertebrae. Spondylitis, it's inflammatory process. It's like rheumatoid arthritis, but it's in the spine, in the spinal or in the vertebrae of the backbone. So the scenarios may be presented with back pain or back stiffness. Questions to ask: when is the pain and the stiffness worse? Does this stiffness last longer than 3 minutes in the morning? Which part of the back is affected? And what are there and other joints affected? What are other joints affected? How long ago did you first notice the symptoms? Any inflammation or redness of the eyes? The same package. Whenever you have rheumatological disease, ask about the pain and analyze the pain on a scale from 1 to 10. 1 is the least and 10 is the worst. How you can score your pain, how you can describe your pain, and what are the factors increasing the pain, for example, movement or rest or what, and what are the factors that relieving the pain? Is it responding to painkillers or analgesics or ibuprofen or paracetamol? So what relieves the pain? Then you ask about any change in the hair, falling of the hair, redness of the eyes, any mouth sores, any skin rash or skin rash and sun exposure, any manifestations related to the chest, GIT, cardiovascular. So all the manifestations related to the chest, cardiovascular, and GIT should be asked. So ask about any manifestations related to the skin in order to exclude the presence of other autoimmune disease like bullous diseases, pemphigus vulgaris, or bullous pemphigoid, psoriasis, vitiligo, whatever. Ask about manifestations of other autoimmune diseases like inflammatory bowel disease, celiac disease, pernicious anemia, type 1 diabetes, all the associated autoimmune diseases. Addison disease, you should ask about postural hypotension. Any dizzy spills when you are changing your position from sitting to standing. Attacks of hypoglycemia, feeling hunger pains with sweating and shaking of the hands, and lack of concentration. These are the manifestations of hypoglycemia. Addison disease. And ask about any other disease like type 1 diabetes, any change in the body weight, more frequent your waterworks or frequent going to the toilet, dryness of the mouth, drinking more than usual. So ask about any associations with any other disease. Ask about family history, any problem to the heart, like racing awareness of the heartbeat or racing of the heartbeat. And here in ankylosing spondylitis, make sure there is no valvular lesions, heart murmurs, lung fibrosis, and kidney problems. So cardiovascular, GIT, cardiovascular, chest, and urinary manifestations. Ask about the whole package. Medical history, show me your medication list. This in case you are taking history from a patient with ankylosing spondylitis. Show me your medication list. Medication list will give you a hint about the complications. If there's hypertension, the patient will be on hypertensive medication or on anti-diabetic medication or any other medication, for example, BBIs or any anti-allergic or any other medication. Then ask about social history, which is very important. Social history, with whom do you live with? What do you do for a living? Is your condition affecting your work and your daily or social life? Yes. If you don't mind, I will involve an occupational health officer and a social worker. Is that okay for you? Yes, it's okay. Do you smoke? Yes. How many cigarettes per day? 20. For how long? For 20 years. Smoking is harmful to your health. Advise you to stop smoking. If you are willing, I will refer you to smoking cessation clinic. Is that okay with you? Yes. Thank you very much. You drink alcohol? Yes. How many units per week? Not per day. How many units of alcohol per week? 20 units per week. This exceeding the limits. So I advise you to moderate your alcohol intake. I advise you to moderate or to reduce the amount of alcohol intake, not to stop, except in case of liver disease. Is that okay with you? Yes, okay. Do you drive? Yes. You should stop driving. In case of ankylosing spondylitis, the patient should stop driving. Why? Because he cannot turn the neck to the right or to the left. So this against the safety in driving. And you should inform the DVLA. This very important notice in case of ankylosing spondylitis. Systemic examination. So the patient will be in question mark posture. This because of hyperkyphosis. Walking aids. Protuberant abdomen. The abdomen will be protuberant. Protuberant means curve. So the abdomen will be swollen. Cervical lordosis. Thoracic kyphosis. Cervical lordosis and thoracic kyphosis. Loss of normal lumbar lordosis. Loss, so all the spine will be deformed. Loss of normal lumbar lordosis, so there will be kyphosis. That's the bamboo sign. Sacroiliac joint tenderness, wall to occiput distance. Wall to occiput distance. Ask a patient to put his back on the wall and measure the distance between the head and the wall. Wall to occiput distance. In the normal person, he can touch the wall with the back of the head. The occiput can touch the wall. In case of ankylosing spondylitis, the patient will not be able to touch the wall with his occiput. Schrober test, this you measure you put a mark, so this is on the back. So the dimples of the venous, these are on both sides. So you take one line and make 5 centimeter below and 10 centimeter above, mark the back. This is Schrober test. And tell the patient to bend forward, and the positive test if less than centimeter expansion between the marks above and the mark down, there should be more than 5 centimeter in normal person. Whenever the patient bends forward, this distance should be increased with more than 5 centimeter. In case of the patient is less than 5 centimeter, this positive Schrober test. Chest expansion, respiratory, there will be limited movement of the chest. And in those patients, you will find ankylosing spondylitis. Any rheumatological case, expect the presence of pulmonary fibrosis. So you'll find end in respiratory crackles, which are not changing, they are fixed, not changing with coughing. Cardiovascular, early diastolic murmur, and displaced apex due to aortic root dilatation. So the murmur in the heart is related to aortic regurgitation. Aortic regurgitation, you will find early diastolic murmur. Aortic regurgitation, there will be early diastolic murmur, and there will be left ventricular enlargement, left ventricular hypertrophy. The apex will be displaced outwards and downwards. In case of right ventricular hypertrophy, the apex beat will be displaced only laterally, outwards. In case of left ventricular hypertrophy, the apex beat will be displaced downwards and outwards. Skin extensor aspects and nails for features of psoriasis. Sometimes, as I said, there will be association with other autoimmune diseases like psoriasis. Tendons, Achilles, there will be Achilles tendonitis. So Achilles tendonitis, there will be pain in the back of the foot, Differential associated, look for any other arthropathies like psoriatic arthropathy, but believe me, for the exam, this is a spot diagnosis. Psoriatic arthropathy will not be mixed with ankylosing spondylitis, reactive arthropathy or reactive arthritis, inflammatory bowel disease associated with arthropathy, osteoarthritis, mechanical back pain, malignancy, diffuse idiopathic skeletal hyperosteosis. So all these are just theoretical differential diagnosis. Investigation, blood pressure is most important. You should think about measuring the blood pressure, ECG, urine dipstick for proteinuria, oxygen saturation for hypoxemia or hypoxia, in order to exclude the presence of any complications related to the heart or related to the chest or respiratory system. Blood test, fasting, full blood count for anemia, the inflammatory markers, erythrocytic sedimentation rate, and C-reactive protein will be raised. The kidney function test may be reduced secondary to amyloidosis of non-steroidal anti-inflammatory use. Here, the HLA-B27 will be positive. The characteristic bamboo spine with only plain film or plain X-ray, this is diagnosed. MRI spine, this sometimes is needed in order to exclude the presence of any compression on the nerve roots or on the spinal cord. Chest radiogram, high resolution CT chest for apical pulmonary fibrosis, echocardiogram for aortic root dilatation, aortic regurgitation, special tests like spirometry pulmonary function test for treatment, non-pharmacological as usual, and the treatment of pharmacological non-steroidal anti-inflammatory, and you will give steroids and DMARDs. Then the biological treatment, adalimumab, etanercept, or glimumab. These are the biological treatments, adalimumab, etanercept, and golimumab. Nice states patients should have used to at least 2 non-steroidal anti-inflammatory, at least maximal tolerance use, in order to prescribe for the biological treatment. There is a scoring system. It's called BSDAI and VAS scoring system. This is the system which is used for staging of the disease and for scoring for the follow-up for treatment. Joint replacement, osteotomy, these are the surgical What are the causes of shortness of breath related to the ankylosing spondylitis? Apical pulmonary fibrosis, restriction of the chest expansion, this mechanical obstruction, tuberculosis or other infectious secondary to immunosuppression, and the use of tumor necrosis, anti-tumor necrosis factors, the biological treatment, and that's why you should examine the patient for tuberculosis, exclude the presence of tuberculosis before admission of biological treatment. What are the diagnostic criteria? This is a modified New York criteria. This, we will never be asked about the details like this, but this just for your own knowledge. This is the case for ankylosing spondylitis, and read it carefully many times in order to get all the knowledge needed for the exam. But in general, these are the cases commonly presented in the exam. So if you have any questions, please unmute and ask.
Sir, I want to ask, in case of examination for ankylosing spondylitis, do we have to ask the patient to perform movements on the neck and the movement on the hip? Like there are 5, 6 movements on the neck and 4 movements on the hip.
For any rheumatological case, you should ask for movement. So you should ask the patient to move. And in ankylosing spondylitis, you should be very careful because the patient will be unable to give them the full range of movement in the back. He will not be able to give the full range of movement in the back. So that's why Schrober test is indication of inability of the patient to bend forward completely as normal person. So this means limitation of the movement in the back. So for any joint, for any rheumatological case, ask for passive movement and active movement. In those patients with ankylosing spondylitis, you can add to the clinical examination neurological examination of the lower limbs. Why neurological examination of the lower limbs? In order to make sure there is no compression on the spinal cord. If there is compression on the spinal cord, this will lead sometimes to some manifestations in the form of, sometimes if the cervical region is affected, this will lead to spastic barbaresis in the lower limbs. And if the lumbar region, they will lead to sciatica, compression on the nerve roots, and this will lead to lower motor neuron lesion. Flaccid barbaresis or flaccid monobaresis, and sometimes may lead to sensory affection of the lower limbs if there's compression on the spinal cord or on the nerve roots. So neurological examination of the lower limbs, just brief. Tone, power reflexes, coordination, and sensation. Do it very brief in the lower limbs in order to make sure there's no affection of the spinal cord or on the nerve roots in the lumbar region. Neurological examination of the lower limbs. So this examination, you will go for wall test, the wall occiput distance, and the Schrober test, and in the lower limbs, you go for neurological examination. This will be more than enough to cover all the aspects related to ankylosing spondylitis. Any other question, Dr. Ahmed, Dr. Ibrahim?
Yes, there is the question.
Yes, please.
In examination for ankylosing spondylitis, I will go directly to do Schrober test and wall occiput test, or I will do same like other rheumatological for paroxysmal myopathy, for heart, for like this.
In case of ankylosing spondylitis and its spot diagnosis, you will go directly for specific tests. So go for occiput wall test, go for Schrober test, and go for neurological examination of the lower limbs. This is the most important steps. If you have more time, you can go for example, which is very important, go for chest examination. And even you have no time to perform it, tell the examiner, I want to go for chest examination. Why you go for chest examination? to examine for pulmonary fibrosis and pulmonary hypertension and core pulmonary. Why you want to examine the heart? I want to examine the heart for possibility of aortic regurgitation, dilatation of the aortic ring, aortic regurgitation. I will examine the patient for aortic regurgitation. So that's how you perform the exam, because in the exam, you will never be able to perform all the tests, and you will perform full neurological examination, cardiological examination, chest examination, but you tell the examiner that you are aware that these may be complications of the case, and you want to examine the heart, chest, and full neurological examination. So I hope this answers your question, Doctor. Schubert test I will do or only offer. Actually, you should do it. You should do Schubert test, because these are the two tests that are specific to the case. So in case of ankylosing spondylitis, do the occiput wall and do the Schubert test, because these are the two tests specific to ankylosing spondylitis. I hope this covers all the rheumatological diseases. Psoriatic arthropathy, you will find here, it's very interesting case. So look for the skin, look for the joints, and almost the same. Here it's a spot diagnosis, because you will find the characteristic skin rash with silver scales which are bleeding on a scratch. The same skin. So here are, yes, please.
Sir, last time in my outpatient department, I saw a female patient, 60 years of age. She had a complete vitiligo all over the body. She had heliotrope rash, and she had psoriatic rash on the hands, which are sparing the knuckles. She didn't have any proximal myopathy. So I couldn't make the correct diagnosis. It was a mixed type of disease.
As I said,
DS says heliotrope rash,
yes.
vitiligo.
Okay. So take all autoimmune diseases as a package. It's a family package.
Mhm.
Family package. It's only, all diseases are in only one family. One family. So expect all that will make your life easy in life and in the exam. Whenever you find any one of the autoimmune disease, think about the whole package. So whenever you see, for example, psoriatic rash, think about all other rheumatological disease, think about Addison disease, think about thyroid, think about type 1 diabetes, think about pernicious anemia, celiac disease, inflammatory bowel syndrome, and even other dermatological diseases like bullous diseases and vitiligo. So you may find a very specific rash of psoriasis with the specific rash for dermatomyositis, Gotron papules, and you will find this heliotrope rash. So you may find them both in one patient. So this is very reasonable, and it makes sense, and it's logic to find sometimes two types of skin rash. But for the exam sake, you will handle the case as autoimmune disease. So you examine the patient, the skin is spot diagnosis. Examine the joints. So you need to examine the joints. What else? Examine the chest for pulmonary fibrosis, which is very common complication of. Examine the patient for core pulmonary hypertension. So that's how you handle the case. It's easy. In the exam, don't panic. And you should be flexible, and you should be prepared for any scenario. This is how you will be prepared. Take it as a package. Even if you find more than one skin rash, comment on the skin rash. This rash is specific for scleroderma, and this rash is specific for dermatomyositis, and this is the specific rash for psoriasis. So think about arthropathy, examine the joints, examine the chest, examine the heart, examine the other systems related to the disease or related to the lesion and give the differential diagnosis. Just be flexible and be prepared. Knowledge is your trust. It's anti-panic treatment. Anti-panic is the knowledge. If you don't know, you will panic. If you have the knowledge, you will never panic. You will never panic if you have the knowledge. The knowledge is there, but sometimes our knowledge, we don't have time. We are not able to memorize. We are not well prepared. We didn't give much time. We are busy with our work. We are busy with our families. So we don't give enough time to the exam. So know what is the needed knowledge for the exam. Don't go deep, distract yourself, and you will lose your confidence. Too much knowledge, but you will not be able to get it out of your brain in the exam. You will panic. Get the needed knowledge, be prepared, know what are the cases, and go well prepared. Go well prepared. 20% of the knowledge will yield 80% of the outcome. 20% of the knowledge will yield 80% of the outcome. So select the important and effective 20%. Don't go for 100%. So be selective. Know what is the knowledge for the exam. We have 5 cases for rheumatology. Just study these 5 cases. See videos. A lot of videos. You will find a lot of videos there in the YouTube and in the past test. You will find videos. Look for the videos and know how to brain map yourself, to have a scheme, to have a checklist. I'm going for rheumatology, I have a checklist. I'm going for a chest, I have a checklist. I will examine an inspection, then general examination, then local examination. Local examination, I'll go for 1, 2, 3, 4. Make checklist for each station. So that's how you will be prepared for the exam. You will never panic. Whatever the station, whatever the case, get the findings. You are sign collectors. Sign collector, you get the signs. You know the signs, collect the signs, and present to the exam. Even if you don't know the final diagnosis, give a differential diagnosis. This is the knowledge. Otherwise, you will panic in the exam and you will lose concentration. Just keep your concentration, keep the self-confidence, and collect the signs. Present the signs to the examiner. What is the differential diagnosis? What is the investigations? As much as you can, because the good news, the examiner has 4 minutes with you. 4 minutes. So these 4 minutes, 1 minute for present your findings, 1 minute for differential diagnosis, 1 minute for investigation, and 1 minute for the management. So the examiner have some restriction. He will never give you hard time with unexpected questions. These are the questions which are requested to be answered. In the scenario, they give the examiner 4 questions in order to get the full mark. The first, present your findings. So how to present your findings is very important. What is the present your findings? All what you got from the examination, starting from an inspection, local general examination, and targeted examination. Get all the important findings. Then, what is the differential diagnosis? You should know some names. Investigations, you should know targeted investigations. Don't go for general investigations. Don't start chest case, don't start with basic investigation. Start with chest X-ray, CT chest, high resolution CT, pulmonary function test, sputum for culture and sensitivity test, then ABG, so specific investigations. If you tell like that, he will go to the next question. How to manage this case, non-pharmacological, pharmacological, and surgical. Just be prepared and get the common question. Don't get a lot of knowledge in order not to be confused and to lose control on your brain. Your brain needs the least amount of knowledge in order to be able to perform good in the exam. This is my advice. So I hope this is clear.
Thank you.
Thank you very much. So you will find the group on the Telegram. Again, in Telegram, as I joined late, no problem at all. And I hope, I'm not sure, because actually many of you say that the Telegram group is difficult to approach, but I want to make sure that, for example, this rheumatological group, you will find all the information. So this is spot diagnosis. This is spot diagnosis. I love these pictures because they summarize all the knowledge in one iMessage. You will get all the knowledge in only one iMessage. So you will catch the diagnosis easily. This is very beautiful pictures. These are silver scales of psoriasis, never to be missed. This is ankylosing spondylitis. Do you think you will miss this patient in the exam? You will not diagnose this patient in the exam ankylosing spondylitis. Systemic sclerosis with scleroderma, Buccal mouse, tapered nose, sclerodactyly, infarction of the skin, glistening and tight skin, tightness of the skin, rheumatoid arthritis. So these are beautiful pictures, summarize the long story in one eye shot. So please tell me if, because here you will find many options. You will find members, then media. If you go for the media, you will find the pictures. If you go for the files, you find all the files. And if you go for the links, you will find all the links. So there are 4 options: members, media, files, links. Because some of you may be first time to deal with Telegram and do not know, because the advantage of Telegram groups, they get a lot of members. We can even up to, I think, 200,000 members. So this is big capacity, and it accommodates all the videos. The WhatsApp groups, short videos, or if you have the link and go for YouTube. But here you will find all the videos here. So videos are very important. Then you will get books. You will find books, can download books on the Telegram. In case of WhatsApp, this will even sometimes make WhatsApp very slow. And if you don't have storage capacity, this will be a problem for the application. So here in Telegram, you can upload books and you can upload videos and high capacity, and you can get the previously loaded material. So that's why here you will find media, you will find files, and you will find links. So I hope you will check your application, if it is working like this or not, and tell me if there is problem. Here are rheumatoid arthritis, and you will find Raynaud's phenomena, rheumatoid arthritis. So these are cases for the exam. The videos are there, and the pictures and all the materials needed for the knowledge. Here you will find rheumatoid arthritis, scleroderma, systemic lupus erythematosus, dermatomyositis, ankylosing spondylitis, and psoriatic arthritis. So if you read this for the exam, one day, revision one day. What is the top on the top of the list? Rheumatoid arthritis and scleroderma. So I hope this is clear and easy to approach. If you have any problem, tell me and I will re-upload. Endocrine revision will be tomorrow. Inshallah, tomorrow, Friday, we will cover all endocrinological diseases. And I will send the files to be prepared. and I need active participation. So please, for tomorrow, I need to read and be prepared and be active participant for tomorrow, inshallah. Tomorrow we'll cover all endocrinological cases for tomorrow, inshallah, session. I will just share the timing and the link on time tomorrow, inshallah. So if you have any question, this covers all rheumatological cases. Rheumatology. What you need is to read. Read and look for videos and look for pictures for spot diagnosis. I'm very happy to have you, all of you, with me today. I'm very happy to have the discussion and the sharing of knowledge. And I wish all of you good luck and nice weekend. Tomorrow is Friday. Some places it's weekend, some places it's after tomorrow. Anyway, enjoy your time, enjoy your life, read, study, and be prepared for the next session. I will share all the files related to endocrinology, and for rheumatology, I will also share all the files again if you don't have access. Good luck and see you tomorrow, inshallah.
Thank you, Doctor. Thank you so much.
Thank you so much.
Thank
for
you for
such a
all
nice.
of you. Thank you.
Thank you, Doctor. Thank you.
Yeah, Dr. Safa. Thank you.